We are Group 1, and this is our sensor-coupled drug-release biomaterial for overactive bladders. So there's a high clinical need for this long-term solution. Overactive bladder is a condition that affects 33 million people in the U.S. alone, and basically people suffer from muscle spasms and infrequent need to urinate. And the risk increases with age, obesity, and smoking habits. So in people 18 to 29, about 15% of patients suffer from overactive bladder. And as you get into 60, 69 years old, 39.8% of patients suffer from it. And it is more common in women, and it affects life in various ways, such as work, school, relationships, and also takes a toll on mental health.
Now, the way that a normal bladder works is by the relaxation and contraction of the detrusor muscle. This muscle is supposed to be relaxed while it is filling, and it will give the first feeling of voiding or urinating once the bladder reaches half its capacity, which is about on average 200 milliliters. Now, the bladder has an average capacity of 400 to 500 milliliters, on which at the moment of voiding, the detrusor muscle contracts and the urethra relaxes, allowing the process of urinating. It is also important to mention that 54 to 55% of all your OAB patients experience detrusor overactivity. And the way that an overactive bladder is affected from a normal one comes in the deformities present in the detrusor muscle. Some of these effects are increased myogenic activity, which is the increased blood pressure, which causes the muscle contraction. There is also the presence of fused tetanic contractions. That is when the muscle contraction activates the motor nerve and emits an action potential at a very high rate. There is also an increase in connective tissue between muscle fascicles. This manifests visibly in the form of wrinkles in the detrusor muscle. These problems are responsible for causing the need to urinate very often, as the bladder sends erroneous signals at half its capacity rather than a fuller one. Now, going into the current approaches, there are many solutions available to treat OAB. However, they fall short in a few aspects, for example, price and longevity. First, here we have the Botox treatment, which lasts about 6 to 9 months and has an average cost of $800 to $900 per treatment. Secondly, we have nerval implants, which are implanted on the sacral nerve, which proves to be a longer term solution going up to 15 years, but with a higher cost of $22,000 and a therapy cost of $14,000. We also have the pharmacological therapy solutions, which uses different substances like oxybutynin and tropsium, which have an average price of $700 annually and need to be taken up 3 times daily, depending on the patient. It is also important to mention that there are also even cheaper options like adult diapers. However, these are the most disruptive on the day-to-day life.
Essentially, our device is composed of a biomaterial, a muscle relaxer, and a pressure sensor that all work in unison. So as you can see in this diagram of the bladder, the darker purple area represents the area where it fills with urine. And then once the bladder fills, the urine puts pressure on the bladder wall, which can then cause the detrusor contractions. So this wireless pressure sensor would be implanted directly in the submucosa area, which is that pink region, and through a surgical procedure. It will detect changes in the submucosal bladder pressure, which would correspond to the bladder fullness. So as for the biomaterial component, we will be using polypyrrole, which will continually release a drug relaxer called, a muscle relaxer called baclofen, which has a short half-life and a high bioactivity. And this will be released to the detrusor muscle to prevent those involuntary detrusor contractions. And this drug works by facilitating the binding of GABA receptors to GABA, which is one of the most common neurotransmitters in the central nervous system, which acts as a muscle relaxer. So once the bladder fills to max capacity and the pressure threshold is reached, the pressure sensor will signal the polypyrrole to stop releasing baclofen. Once it stops being released, the muscle contracts and the person can urinate. So This threshold for pressure will be determined during the surgical implementation process, where we will actually fill the person's bladder to capacity with a catheter, and then we could determine the pressure that corresponds to the max capacity. That way it'll be personalized to each patient.
In terms of approach, we use a feedback system that controls bladder contractions relative to the patient's bladder size. Our group took our knowledge of natural neuroinhibitors like GABA, nerve signals, as well as muscle contractions in order to design a long-term implanted drug delivery system that will ultimately block the overactive signal propagation and thus inhibit muscle contractions until a desired pressure is met by the force sensor. And this will prevent the random spasms and increase the overall quality of life for the patient. And to clarify, we created this diagram. And if we start with the condition on the left, an empty bladder will exhibit a low pressure. And the empty bladder triggers the release of baclofen to prevent the overactivity and keep the detrusor muscle relaxed so the patient feels no urge. And then when the bladder is full, the high pressure will then surpass a threshold that causes the sensor to stop releasing baclofen so the detrusor muscle can contract and the patient can void. And then in terms of cost, we chose a cost-effective polypyrrole to help make our product affordable. Polypyrrole costs about $94 in a 10-gram pack and can be ordered from companies such as Millipore Sigma. This is relatively cost-effective given that its favorable biocompatibility and biofunctionality ended up becoming integral parts of our design. And we also have the cost of the drug baclofen, but this can be as low as $1 per 50 milligram dose. And then finally, we have most of our design costs that revolves around the surgical implant procedure. This can run up to around $20,000, but in most cases, this is at least partially covered by the insurance of the patient.
There are many advantages and disadvantages associated with our device. So the main advantage would be that it is a long-term solution where the polypyrrole and pressure sensor should last for life. However, it could be a disadvantage that the drugs would need to be refilled every few months, which is at least more advantageous than daily doses associated with oral medications. Additional advantages include that each design is personalized to each patient for continuous pressure monitoring with a pressure threshold specific to each patient's geometric bladder capacity. So with that being said, one of the biggest disadvantages would be that a surgical procedure would be required to implant this device, which would be very invasive and requires the use of a catheter. However, one of the benefits of that is that you could have the implementation and the pressure threshold determined in the same appointment. However, this is just one large invasive surgery for a lifelong solution, with drug refills being able to be performed without making a large incision. As with any surgery, there is always going to be a risk of infection, which can be minimized with proper sterilization techniques. In order for the polypyrrole to be successful in the bladder wall, it must mimic similar mechanical properties of the detrusor muscle. So the Young's modulus is the one that we want to consider the most, which would be 0.25 megapascals for the bladder wall. Polypyrrole can have high values for the Young's modulus and its strength, magnitudes much larger than those for the bladder, but we can manipulate the mechanical properties of this biomaterial during the polymerization of it. So for example, the type of the dopant being used, and then if you increase the oxidation potential or if you add reactants, especially ferric acid, it can decrease the Young's modulus immensely, making it go from magnitudes of 900 GPa all the way down to 1 MPa. That way we could tailor the polypyrrole specifically to mimic the bladder so that it could perform better without adverse tissue interactions.
All right, the device market standards. So the Federal Food, Drug, and Cosmetic Act, obviously this is a class 3 device, but it requires that there's pre-market approval before you can market or sell this product at all. So there's a few examples of similar models that one of them is the neurological therapeutic device. It basically connects to your spinal cord and delivers pulses. And this requires a pre-market approval from the FDA as well as a PDP if you have drugs included in it, which ours will. So a prescription drug plan. And then sacral nerve stimulation for urinary incontinence. United Healthcare did a review on this, and patients basically need to be refractory to conventional therapy and be appropriate surgical candidates. So they need to be, they can have anesthesia and all the procedures they must be qualified for. And in the testing of patients over time, they need to have a 50% or higher improvement from the test, and their clinical history also needs to be laid out very clearly, which is on the next slide. The FDA standards for data approval over time as you test your product and your drugs on people, you need all of these different things: pre-treatment, post-treatment, and then any adverse effects, anything that went wrong during the experiment, or any patients that you had to disqualify. So you have to lay all that out here and basically check all these off.
Moving on from that, because our design is a drug release system, we would need to conduct a series of functionality tests to make sure that it's meeting the design requirements. In terms of the sensor, it will be tested in terms of electrical and mechanical properties. The conductivity will be measured using a high resistance meter, since the resistance is caused by a change in strain. A balloon and an ex vivo pig bladder will be used to mimic the bladder wall due to the similar elastic properties to the actual detrusor wall in humans. And then finally, the average of around 500 milliliters for a maximum bladder will be used to make the calculations for the force sensor and make the setting for the full bladder for the patient. And then moving on, we have the test for the polypyrrole film. This needs to be tested for its controlled drug release, and we will do so by using alternating periods of electrical stimulation, since it's the electrical stimulation that will stimulate the release of baclofen in vivo. And the time periods that we're going to use for this period of electrical stimulation are 0 hours, 24 hours, 6 days, and 28 days, with the 0 hours being our control, because it basically means that we'll have no electrical stimulation and hope that there is no baclofen release. There's also some other in vitro testing that is going to be important for our design. For example, we have the biomechanical testing, which we'll do using a uniaxial test at about 0.3 millimeters per second. The parameters that we're trying to observe here are the Young's modulus as well as the tensile strength and strain. And we want to make sure that our target results are as close to the in vivo bladder detrusor wall as we can. And then moving forward, we're also going to test for hemocompatibility. To do so, we're going to use a static blood incubation and try to observe a hemolysis that is less than 2%. And then for cytotoxicity, we're going to be using a trypan blue cell counting method in order to track the cell viability before and after fibroblasts are seeded with our polypyrrole. And this will make sure that the polypyrrole is not having toxic effects on the cells. And then finally, we'll have a cytocompatibility test, which is similar to the trypan blue cell counting, but involves a live dead cell staining of 3T3 fibroblasts. And using those, we can then qualitatively observe them for growth as well as their interaction with the surface of the polypyrrole.
Along with that, there's going to be some in vivo testing. For cytotoxicity, we want to do urinalysis, where you basically look at urine under a microscope. And the things we're looking for are mucus and immunoglobulins. Those are the first line of defense the bladder uses against bacteria, but also pH changes such as acidosis or alkalosis, crystals, color, all of that. That's signs of infection, so we're going to be looking out for that. Inflammatory response and neurovascularization. It was the same study using rat bladder cells. So for inflammatory response, for both of these experiments, the cells are being removed at 1, 3, and 5 weeks. Inflammatory response, you're looking for changes in neutrophils, lymphocytes, and plasma cells. So you're basically gonna look for those, and then that would be a sign that bacteria got in and there was an inflammatory response. And then vascularization, you're basically looking for a new number of blood vessels, so increased macrophage activity.
Our approach hopes to provide many benefits to the patient, as it aims to reduce the stress of taking daily medicaments and having to worry about urges to urinate in the reservable locations. We hope that with this approach, we can improve the mood, mental health, and overall well-being of patients suffering from OAB, as well as going through the process of treatment. Thank you.